boys or boys? They're both boys or what?
You're with Deja?
Me? I don't know
I'm
what
just kidding.
I'm sitting next to you.
You dog trade? You trade him or no? So, when you train, oh, when you use a crate to train them.
Well, we went to do the school for the month, and then
What do you do to do school?
and we do what they start, obedience training, body training.
How much is the best? Let me ask you. Yeah.
Oh, I remake that face. It's like it.
What I think about it.
It's what, so 12? Alright. We have
It's what?
events.
Stairs, when I got done, I would get rid of that.
Oh, so you're pretty cool. Or,
Instigating trouble, tie, and then we kind of get some stuff playing with me and stuff we went out of the house.
that was the weekend. The bonfire.
They closed it's still right now.
Oh, that's right. Wait, it
Right when we
was,
was on our way to get there.
it was on Saturday? Oh, okay.
So we just had to move it.
How was the weather in the beach?
I don't know, I didn't get to
Oh,
get
you
there
never
yet.
got
I was about to walk out the door. My cousin said he'd get there to 7 in the morning.
She's from Mexico, home to the valley.
Why did y'all?
Glad I went there and said this.
Jacksonville for a class.
Yeah.
Basically like physical therapy.
Oh, okay.
Sick.
Cardiovascular patients.
So it's basically cardio.
You go to a major island, you probably didn't go anywhere.
No, we just went to Jacksonville and then we drove to Orlando and Cape Canaveral and then drove to Miami.
I walked out
So
for
we
like a
did the whole
couple
thing.
times and felt like
Miami is
walked outside.
You like it or
I
not?
was college first coming
I think I
out.
took 2 showers.
Yeah, I wish I could.
Because I was just walking there, you know, I was trying to watch it just,
Yeah.
and then I was
I
cooking,
flew
so
into Charlotte.
it was scary as hell.
You go to Disney World?
Drove by. My daughter's only 9 months old. Why would I take her to Disney World?
No, that's a little different.
So my name is Frans. I work for the respiratory department. Some of you I know, and some of you I don't. I haven't seen you. I work in the ICU most of the time. Also in the hospital itself, or in the subacute once in a while. So first we're going to talk about some commonly used terms in respiratory. So first we'll have SpO2. You guys have all seen that. Saturation of peripheral O2, that's when you use the fingers or the toes or the ear to measure the saturation of the patient. Sometimes you have a little hard time getting the reading to come up. Most of the time it's when the patient is moving their hand or they're gripping something, a walker or something, then you can't get a good reading on it. So you just have to let them relax the hand and then it'll start picking up the signal again. Get a reading. So if they're gripping something or moving their hand, just wait. Just have them hold their hand still, because otherwise you can't get a good reading. It's unreliable. Then we have PO2, which is the partial pressure of O2, and that's the number that you get when you have an ABG. You get the PO2, and that's really a number that you can rely on the O2 saturation of the patient. So it needs to be between 80 and 100. If it's below that, it's not good. If it's above that, then we have to titrate O2. Then we have the FiO2. It's a fraction of inspired oxygen. Normally the O2 is like 20 to 21% in room air. If you give a patient oxygen through an nasal cannula, then you can go up to like 32 or 36%. So it's a fraction of the inspired oxygen, that's what they call when you titrate O2. Then you have CO2, carbon dioxide. We also look at that as the waste product that the patient breathes in oxygen, you get the oxygen exchange, the CO2 gets blown out and the O2 gets absorbed in the body. If the O2 or the CO2 doesn't get blown out, then you get the patient becomes acidotic. And then we have for ventilators we have AC, assist control. That's when the patient is on the ventilator and has a set rate, set volume, and FiO2, and sometimes also PEEP. PEEP we use. Positive end expiratory pressure. So at the end of the exhalation, there will be pressure left in the lungs. That's what PEEP is for, and it gives you better oxygenation because you keep open the lungs and keep open the alveoli, and you get better oxygenation, better gas exchange. That's what PEEP is for. So people that have problems with oxygenation on the ventilator, they usually put on PEEP also. And then you have SIMV. Synchronized intermittent mechanical ventilation. It's basically the same as AC. The only addition that you have is pressure support. So with SIMV, the patient, with AC, the patient has a set rate and he breathes what the ventilator is set at. That's what the ventilator gives him, that's what he gets. He can overbreathe or breathe more than what the rate is set at. Like if the rate is set at 14, the patient can still breathe 20, but the only volume he can get is what the ventilator is set at. It's set at 500. That's all the patient gets with every breath he takes. With SMV, you have a little more variation because you add pressure support to the settings. And with pressure support, when the patient takes a breath himself, then he can take in as much air as he wants. That's what the pressure support comes in. So if the patient initiates a breath, then he can breathe in 800 or 900 or 1,000 or 200, whatever he can do. But it gives him a little more freedom of breathing and getting more or less if he wants more or less. Usually SMV is used when the patient is being weaned. That's the first step in the weaning process. On AC, the patients are usually mostly sedated because it's for most of them it's uncomfortable being on assist control and having the ventilator breathe for you. So it's for most people it's uncomfortable. So when we start weaning, then we usually wake them up, and then we go to SIMV or just to straight pressure support. And on straight pressure support, then the patient only has the pressure support set. That is a pressure that every time the patient takes a breath, it pushes the air through the tubing and helps with the work of breathing. So the patient gets a little assistance. Because it's very hard to breathe through the little ET tube and the whole tubing of the ventilator, so you have to overcome all that when you take a breath in. So that's where the pressure support comes in. Then we also have bi-level and APRV, which are settings when we use with really sick patients that have ARDS. And usually patients like that on bi-level and APRV you can't do therapy with, or because they're too sick. They're usually sedated and sometimes also paralyzed because of the settings on bi-level and APRV. Works with high and low pressures, and sometimes an inverse ratio, so it's really uncomfortable to breathe like that. Because normally your ratio is 1 to 2, so inhalation is 1, and then the exhalation is usually twice as long in normal patients. So with bi-level and APRV you sometimes work with 3 to 1, 4 to 1, or 12 to 1, really the opposite, complete opposite. Then we'll talk about some lung conditions. So we have some lung conditions and some terms that we use. Start with pleural effusion. Pleural effusion is excess fluid that accumulates in the pleural cavity. Usually you have, I'm not very good at drawing here, but usually you have the two lungs. And then you have like a space in between here. There's like a membrane around it. And in the space here between there is like fluid. So when you inhale and exhale, that it has a fluid motion. If there was no fluid in between this sac that's around it and the lung itself, it would be really like throbbing constantly. So it would be really uncomfortable. And that's where you have sometimes when the fluid disappears that you have pleural rub, and you listen to the patient and you can hear it makes a rub like a squeaky noise. So pleural effusion, you have excess fluid in the pleural cavity here. So then it puts pressure on the lungs, and so it becomes very hard for the patient to breathe at times that the pressure gets really high. Then you have pulmonary infiltrates. It's usually a substance like pus or blood or protein that lingers in the lungs. You can see that on the X-ray. Then we have pneumothorax and hemothorax. Pneumothorax is when there's air introduced in the space between the lung and the sac that surrounds it. And so usually with hemothorax, pneumothorax is with air, and then hemothorax is when there's blood in between there. So in both cases they usually insert chest tubes, and they get put on suction to get the air out or the blood out, and then eventually they clamp them off, or they put them, so when there's enough that's drained out and back to normal, then they clamp them off and take them out eventually. That's when they're hooked up to that little bubbling thing that's next to the bed most of the time. Sometimes it's the left side or right side or both sides. So with pneumothorax you have that there's air in that pleural space, and with hemothorax there's blood. And it's usually hemothorax is caused by like accidents, like a trauma, car accident, motorcycle accident. And it's a rupture of the membrane, and then blood can go into the cavity or into that space. Bronchiectasis, it's a permanent enlargement of the parts of the airway in the lungs. It has a chronic cough, and the patient also has usually sputum, like yellow, greenish sputum, a lot of mucus production, and because of that, all the mucus in the airway, you get shortness of breath with the patient. And sometimes they even cough up blood with that too. Then we get to emphysema and COPD. patients with COPD or with normal patients that do not have COPD, they like all of us, we usually live on the we breathe different than COPDers. We live on the hypercapnic drive, and what that means is that our brain senses the CO2 in our air, in our airway in the lungs, and it braces off your breathing off of that. So if your CO2 is high, you start breathing faster to blow off more CO2. So the brain automatically does that. So if there's not enough CO2, then it starts slowing down the breathing. So, but with COPD patients, you can draw in here too. Normal lung tissue, like the alveoli, they look like there's like millions of these little air sacs that are like connected and then filled with air when you take a breath in. But with COPD patients, what happens is over time, these little, like the connecting walls between the little air sacs, they disappear. And what happens is then you get one, like a big balloon. That's what the lungs look like. It's not little air sacs anymore, but it's just one big blob, one big balloon. So, and that slowly happens over time with COPD patients. And because of that, you can imagine when you have 1,000 little balloons, you only have to put a little effort in to blow them up. But when you have a big balloon and you try to blow up, the first part is really, really hard to get air into it. So with COPDers, they don't want to let all the air out because it's really hard to take a breath in again. So that's why they do the pursed lip breathing. Usually they try to keep pressure in the lungs, so like that, and then they try to keep the pressure in the lungs so it's easier to take a breath in again. So, but they, with COPD patients, because of the change over time with that becoming just one big balloon, it changes in the brain, something in the brain too, that they start living off the hypoxic drive, yeah. So what that means is that instead of measuring CO2, the brain starts measuring the O2. So with COPD patients, if you give them too much O2, breathing slows down until it eventually stops. So that's why COPD patients, you don't want to give too much oxygen over a long period of time. I'm talking 24 hours or more. So you can give them a non-breather or a lot of oxygen, 100%, for a short period of time. But you have to keep in mind that they live different than we do, and if you give them too much oxygen, the brain will eventually slow down the breathing so much that they stop breathing. So with COPD patients, usually you can see that they're usually on like a 1 liter or 2 liter nasal cannula, and that's all they need. And then even if the saturation is 88, 90, that's still enough for them. If they look fine, they act fine, they talk fine, then there's nothing wrong. They usually live on a lower, we call them the 60-60 group, because the PO2 and the CO2 is usually 60 and 60. And in normal person without COPD, and your PO2 is usually 80 to 100, and the CO2 is between 35 and 45. So they live on a totally different area when you do an ABG on those people than on people without COPD. So COPD is considered an obstructive lung disease. With COPD, asthma, and cystic fibrosis and bronchiectasis, they're obstructive diseases. With obstructive diseases, you get shortness of breath due to difficulty exhaling, because you can't, if you let all the air out, then you have a really hard time breathing back in again. But you also have restrictive lung diseases, and they are caused by stiffness in the lungs. And the people that have restrictive diseases, they usually can't fill the lung completely with air because they're so stiff that it's really just a tiny little bit of air that they can take in every time. So they usually are very short of breath and breathe really fast usually. Let me see here. we also have empyema. It's a gathering of pus in the pleural cavity, so if there's pus in here, also then it's called empyema. There are all these different names. I did make a printout or a copy, should be in your email with all these things in there, so you can read it if you need to see it. So it's all printed out in your email because it's just a lot to you can't remember all this stuff. So. And then pulmonary edema. There's a fluid accumulation in the air spaces, and usually with pulmonary edema, when you listen to a patient, you can hear it sounds like water, like a lot of water is collected in the lungs, and it sounds different than bronchi or crackles. It just sounds like your patient is, it's like a sponge. That's what it sounds like when you listen to a patient with pulmonary edema.
And that's still all in the pleural cavity.
Yeah, and it puts pressure on the lungs, yeah. So, and on the heart. So the heart has a harder time beating, and the lungs have a hard time. So the people are usually short of breath, the saturation drops really fast. So with patients with pulmonary edema, they end up doing usually is put them on 100% oxygen, and then give them Lasix to drain the fluid out. And then usually within a couple of hours, they're back to normal. Fibrosis. These are excess fibrous connective tissue in the lungs, and the lungs are very, very stiff, so the people have really hard time breathing usually. They take tiny little breaths, you can barely hear any air moving. Then we have ARDS, acute respiratory distress syndrome. It's usually when the lungs go into shock. It's usually with sepsis. Patients that come in with sepsis, they have a high risk of going into ARDS. And when you go into ARDS, then most of the time you end up on the ventilator on bi-level or APRV because it's really difficult to oxygenate them again and get them to be in the normal range because the lungs are just going into shock and don't work the way they should work anymore. So sometimes you have a really hard time with the gas exchange to get the patients to oxygenate. And it's happened by, or it's caused by sepsis and also sometimes trauma, car accidents, motorcycle accidents, and lung infections. And then we have pneumonia, you have interstitial pneumonia and alveolar pneumonia. We see most of the time alveolar pneumonia. Alveolar pneumonia is inflammation of the alveoli, of the little air sacs in the lungs, the tiny little balloons. And it can be viral or bacterial. So they have to check and see which one it is and then treat them accordingly with antibiotics. But it also, because of the inflammation, it makes restrict the airflow, so it becomes harder for these people to breathe and to oxygenate. Now we're going to breath sounds. Breath sounds, when you listen to the patient lungs, you can hear when they're clear, you hear the air moving and it sounds just like air moving. It's hard to explain, but when the patient has rhonchi, you can hear that it makes like a snoring noise most of the time, and it can be everywhere, lower, upper. When you listen to a patient too, and you hear like a wheezing noise, it's usually on inspiratory or expiratory. Most of the time it's expiratory, but it can be both. And yeah, it's a wheezing and high-pitched wheezing noise that you can hear, and you can hear that also it can be anywhere. Rills and crackles, you can hear those most of the time at the bottom part of the lungs when you listen to the lungs. What that's caused by is by the little air sacs that pop open when you take a breath in. It's most of the time when they take a breath in and you hear a popping noise, crackling or rill, that's what they call rills or crackles, the same thing. It's when those alveoli pop open all of a sudden, that's what the noise that you hear. Then you also have stridor that you come across every once in a while. Stridor you hear mostly up here. When you can hear it here also, but it's more pronounced in the neck when you listen to the neck area, and it's really like a high-pitched wheezing noise also. Most of the time that's caused by extubation. Right after the patient gets extubated, sometimes they develop stridor. We try to give them epinephrine treatments, but most of the time it doesn't work. And if you have a case like that, and the patient gets really short of breath and you can hear stridor, we do have to intubate usually pretty fast, because you can't wait too long, because eventually the whole airway will be closed off. This is just an inflammation because of the ET tube has been down there. Usually it's when patients are intubated for longer periods of time. If it's been down there for so long, there's a balloon at the end. So we put air in the balloon so it puts pressure on the tissue and the airway. So if you take that out after 2 weeks or so, then you might have that the airway gets irritated because of that tube been there. And now the tube is gone. Now it will get inflamed and swell up.
Is the tube in the fluid itself flexible or is it rigid?
What do you mean?
The material, is it very flexible or is it very...
Well, it has those the cartilage rings around the airway. So, but there is still tissue that swells up and closes the airway off. Yeah, and because of the ET tube and the balloon itself, because you put air in it, so it closes off the airway. So, and it does put pressure on the surrounding area, and that's where usually the stridor happens.
A lot of people tell me they have sore throats after.
Yeah, it's a couple of days afterwards usually. Yeah. So we tell them not to talk too much in the beginning, the first couple of hours. So to drink fluid, and that's why we put them on the aerosol after the extubation just to cool the throat and make the swelling less. Yeah, to help with that or aid with that. And then usually after a couple hours we put them on a nasal cannula after that. And we're going to oxygen delivery devices. So we'll start with the simple ones, the nasal cannula. Everybody's seen these. These usually go from 1 to 6 liters. You can't go any higher than 6 liters. If you go above 3 liters, we usually use a humidifier because people's nose gets really dry and they get nosebleeds sometimes. So if you don't use the humidifier. So this goes from 1 to 6 liters. If you go above that, the patient is not oxygenating, and we usually go to a simple mask. Or if you have a patient that's a mouth breather on a nasal cannula, then you have to go to simple mask. Simple mask goes from 6 to 10 liters. So it covers both nose and mouth. So for some patients that works better when you take them walking. If they're on 6 liter nasal cannula and you want to take them walking, you might put them on one of the simple masks if he's like borderline, so just to give him a little bit more during the walk.
I have a quick question while we're on that. Do you need an extension because you need to be able to walk the patient to the bathroom? Where do you get those little adapters to?
They're usually in the clean core and in the respiratory card. On the top, usually on the right side, there is like a plastic bag with those connectors in it. Usually,
They'll find it like the.
yeah, the little code like the connector.
I just usually rip it apart.
Yeah, but ask the RT because I always carry some with me.
Right.
So if you see me, then just
Sometimes
ask me.
some places have been, they're not, they have had an RT look and stuff.
Yeah, but usually they're in the clean card in a plastic bag. There's a plastic bag on the top right usually. And then we go to the venti mask. The venti mask is one of these, and then I don't have the mask for it. This goes on top of it, so just like a mouth and nose. And then there's a venti mask. It goes from anywhere from 28 to 50%. It also has a liter flow on it. So I don't know if you want to look at it. It tells you if you have a percentage O2 on both sides.
So you can
and then you
check the
and,
percentage of O2 that's in the air.
and then you have to change the O2 flow accordingly. See, for like 50%, you need like 15 liters, I think. It says, yeah. So, with the venti mask, I was gonna talk about when people have trachs. If you have a patient with a trach and you want to walk a patient with a trach, you can either walk them without the aerosol, or if they need oxygen, you can use one of these with a tube on it like this
To the,
to the
if they're
trach,
not on a vent,
to the trach mask. Yeah, if they're not on the vent,
right?
and then you can use the trach mask. You know, take it on.
We just normally use the trach mask straight to a tank. We don't use it.
Yeah. So, but usually, this one you can just you can adjust the percentage. That's why it's easier.
Well, I mean, in substitutes when we do it.
Yeah.
We usually just use like the little aerosol thing.
Mhm.
It's like a little,
Yeah.
the white
Yeah.
bubble thing.
Yeah.
Instead
So,
of
but this is, yeah, how,
usually more flexible.
yeah, so we usually recommend doing it like that, so. And then you can put them on an oxygen tank with that and then just walk them, yeah. And then we have, the aerosol itself, usually patients are, when they're on aerosol with the trach, usually it's to humidify the airway because you bypass the upper airway, which usually humidifies the air that you breathe in. But because that's bypassed with a trach, we have to give them aerosol. That's why. That's the main reason why. Some of them are on air, and some of them are on oxygen. You just have to check and see. Because sometimes it's very deceiving because the patient is hooked up to like a flow meter, and it looks like it's oxygen, and it has a percentage with the bubble and everything on it, but it's just air. So you have to just look which flow meter it's on. So even the nurses sometimes write down the patient was on 35%, but it was just air because they just read on the bottle and then don't realize it's just air. And then we have the non-rebreather. That's the one with the bag on it. It needs to go from 15 to 25 liters. 15 liter minimum, and the bag needs to be inflated. If the patient is breathing and the bag deflates and inflates every time the patient takes a breath, you have to increase the liter flow to up to like 25 liters or so. We usually just turn it up all the way to the top.
What kind of medical conditions will they be under using that?
Those are usually people that do not oxygenate very well, and I would not recommend walking them, or because I would just leave them alone. Because this is one step away from either BiPAP or intubation, and they're very close to either one of those.
That's a good idea that we don't have to worry about doing
Should
the
remember
amount.
that. Make sure you remember that too.
There's some people that will try to see a patient and they want that bad.
That's it.
And then you guys have all seen the high flow. High flow is used in patients that
After bronchoscopy or something.
or the patients that have like a little elevated CO2, but it's not enough to go to a BiPAP. Sometimes you see them in conjunction or work together with a BiPAP. That patients usually,
We have a lot of COPD patients on these things.
yeah, but they usually are on the lower percentage too, yeah. So this one you can. It's condensation. So if you ever have to put one of these on, turn it on first before you put it on the patient, because there's a lot of water sometimes that collects in there when you turn it off and turn it back on, because it's warm air that blows through, or gets warmed up by water, but it also condensates because of that. So you don't want to blow a whole bunch of water in somebody's nose. So, but most of the time you guys don't deal with these or take these off or put these on. The nurses sometimes do, so because they want the patient to go to the bathroom and this one doesn't reach, then they just use a mask or something with a tank or an extension.
So let me ask you, if they were on high flow, what would be an alternative if we wanted to get them out of the room? Because almost 99% of the time.
The only one is the non-rebreather if they're already on.
Would be a lot of
Or
them that are
simple
on that,
mask
we
and
don't touch
non-rebreather.
them.
It depends on what they are. We recommend not to do
Not
go
to change it.
walking if you're like 30 liters and 50%. If you're below that, then you can change to a mask, a simple mask, or
So what's your threshold again? If you want.
30 liters and 50%.
Yeah.
So, because if they have 30 liters and 50%, they're still really needy of oxygen. Yeah.
Yeah, cause normally when we get these, we don't even, we just walk like 4 feet by the bed.
Yeah, or you can go around the bed, yeah, or
So
something
it's
like
hard,
that.
cause those things are so.
Yeah, I know,
Monstrous.
the things are all twisted and the tubing's all twisted, yeah, it's hard, yeah. But if they're below that threshold, then you can usually use like a simple mask or a non-rebreather and then walk them like that. I mean, for the short period that you guys walk, that's usually fine. So these, sometimes, these can blow really hard, 40 liters, and it's, we set it at 37 degrees, and it warms up to 37 degrees so that it's body temperature, so it doesn't feel that it's blowing that hard when the people have these in. Because if you blow just straight full oxygen, that's, you can't tolerate that, but you can feel how hard it blows. Yeah. So, but the nice thing about this is that it helps with oxygenation, and it also, because of the high flow, it eliminates the dead air or the dead space that you usually have in here between the throat and between the lungs that just moves up and down. You don't have any gas exchange there, but because of the high flow, it flushes out more CO2 and makes the oxygenation better. And it also, because of the high flow, it creates like the heat. So every time the patient takes a breath, because of the flow, it keeps the lungs a little bit open, so it gives it a little bit of heat, like a peak of 3, so it can help with oxygenation. So these work really well, and we've been using these the last two years, I think 2 or 3 years. But they work really well. And sometimes, like I said, they get used in conjunction with the BiPAP. Sometimes the patient is on the BiPAP at night, and then during the day on the high flow, or during the day on the nasal cannula. Just depends. Sometimes the patients are on BiPAP 24 hours a day, and those people usually are not able to do much therapy with, because when you're on the BiPAP, that's just temporary. BiPAP is only 3 to 4 days. If they can't resolve the underlying condition or improve the patient, then they either have to be put on hospice care or be intubated. Either way, it's a choice they have to make after 3 to 4 days. Because this is just a temporary solution. And then we go to the ventilators. Ventilators we use in Providence are the 840 that I have here with me. We also have the LTV 1000, which is like the gray little laptop looking ventilator with the red letters and the red numbers. No, they're pretty old too. And then in subacute we have the Flight 60. That's the little new one, and then the old one, the PLV 102, which is slowly being phased out because there's no more parts available for it. They don't get repaired anymore. So every time they break, or then we replace them with the Flight 60. There's only 5 of them left, I think, total.
Yeah,
Subacute, so
many over there.
yeah. So I'm glad those are gone, because I don't like those either. Because the PLV 102, you can't really see much or do much with it. It has no beep on it, so. And the alarms, there's high and a low pressure alarm, and that's it. It's very rudimentary. But the Flight 60 is a full-fledged ventilator, just like the 840, and nice as a nice display. You can do anything you want with the Flight 60 is what you can do with the 840. So patients used to have to stay in the hospital for another day to get acclimated to the PLV 102, the old square box, and make sure that they were able to breathe on that and be okay on that. But now we don't have to do that anymore, because when they go across the street, they're going to end up with a Flight 60. So we don't have to have them stay another day for that. So they can go straight from the hospital to the subacute, even though when they're on an 840, go straight to the flight 60. Talk a little bit about the ventilator. Yeah, it's a little noisy because I don't have an air hookup, so the compressor is constantly running. Just turn this down.
So they say it's air oxygen concentrators too, if they need to be.
Yeah, they have a mixer inside, so usually we hook them up with air and oxygen, and then whatever you set it at, it mixes it automatically.
Yeah.
Yeah, but when you disconnect the air, then the compressor will kick in and pull the air from outside. So usually when you have a patient on the ventilator like this, you have a set rate, AC of 14, and then a tidal volume, a beep, and an oxygen percentage. The bottom part of the screen is usually what the patient is set at, the settings, and the top part is always what the patient is doing. And that's the same with the BiPAPs, with the new BiPAPs, not with this one. But I couldn't get a V60 because they were all used. So up here you can see that the patient is breathing 14, tidal volume is 307, which is what I set it at. That's about right, it has to be around the 300 number. And then the minute volume over here is the tidal volume times the rate. So that's approximately 4 liters per minute. So when you're working with a patient on the ventilator and you do physical therapy with them, you always try to set them up. You don't want to let them be supine, but you guys usually set them up and put them on the edge of the bed, or even if they're able to get put in a chair next to the bed, next to the bed. Sometimes you have that the patient starts coughing. There's 3 levels of alarms on here. The first one is a two-tone like that, and then you have a second one that's also yellow. That's when it keeps the same thing keeps happening. It alerts you that there's something going on that keeps occurring. And then when you have the red one, then you really have to check the patient usually, because then there's something really going on that you have to check it out. Either the tube is kinked or the patient is disconnected, but most of the time happens. So when the patient coughs, see that it does like that. It says peak pressure, so that means the patient is just coughing, and it just creates peak pressure in the system, so the ventilator senses that. So then it beeps once or twice.